evening. So the usual safety information, as you've seen before, and I do consult for Avedro and CXLO. So we've already talked about this a good deal, but the key here, I think, is to set realistic expectations, and especially with epithelium off cross-linking, it's going to take a meaningful period of time even to get back to where they were, before you treated them. And I don't promise any of these patients that the treatment of cross-linking will improve them, and make it very clear that the goal is simply to try to stabilize the situation so they don't progress and get worse. And if they happen to be doing fine just with spectacle lenses, the goal is to allow them to continue to do well with spectacle lenses and maybe not have to go on to contacts or especially fit contact lenses. If they're already requiring contact lenses, I tell them they're going to be back into contact lenses again. But we're really trying to avoid something more invasive, which is a corneal transplant. So the FDA-approved procedure is an epi-off procedure involving 2 riboflavin formulations, Photrexa viscus and Photrexa, along with UV radiation, and it's called the KXL system. And this is a picture of it. Many of you are familiar with this device, and it is the one that we have available to us in the USA. Now, a few thoughts on the post-op period, and Ron mentioned this, is that we're going to make the patients worse initially. I mean, basically, we're removing the corneal epithelium and then irradiating it with ultraviolet light. They need to be counseled, much like a PRK, that there's going to be a period of rehabilitation, there's going to be a period of discomfort, and that there's going to be a period of time when they're going to have difficulty doing their normal activities. And we kind of use an RSVP system, where if they have a sudden increase in eye redness or sensitivity or a loss of vision that's measurable or a sudden increase in pain, then we want to hear from them immediately. So we let them know what it is that we want them to look for, to let us know that they need to be seen. And with a large epithelial defect, there is a risk of sight-threatening infection and the like. So you need to be available, or one of your partners does, basically 24/7 if you decide to do these types of treatments. And we let them be back and fully active. I tell the patients they can do anything physical, that's not an issue, but we tell them they can't swim in a pool or jump in the lake after the procedure for 2 weeks. And we do let them take a shower or a bath, whatever they like. And medical therapy is important. And our medical therapy is pretty much the same as the medical therapy that we use for a PRK. Now, at least 70% of these patients are in the hands of an optometrist, not an ophthalmologist, and many of us are consultative ophthalmologists, so we're seeing patients on referral. We still have challenges in this area, and I think one of the things that if you in your area decide to become the treater of patients with keratoconus and adopt collagen cross-linking, it's really important to reach out to the optometric community and let them know that collagen cross-linking for progressive keratoconus is the appropriate treatment, because many of them were trained in their training programs that the treatment for keratoconus is a contact lens. And we all know that a contact lens, while it masks progression, in many cases it doesn't really stop progression. And so there is an educational process that is still ongoing and needs to be ongoing. We want to catch these patients early, before they've progressed to the point where actually they're even dependent on a contact lens. And we can teach, there was a time before topography. It's certainly a very important tool to us today, but there are many things that a optometrist who doesn't have topography can look for. They're usually quite skilled at retinoscopy. They can do keratometry and look for a tilting of the Myers. Even looking with a direct ophthalmoscope, you can recognize the reflex of a keratoconus patient and the like, and they should be aggressively in patients that are progressing, which is the common thing even just as a standard myope, but progressing meaningfully with myopia, but especially astigmatism, they should be aggressive, I think, at referring them in to have us check them out and see whether or not they have keratoconus, and then offer them treatment if they're meaningful progression. And of course, nearly always, we end up needing to treat both eyes. And as I mentioned, I treat the worst eye first, but the worst eye isn't always necessarily the worst refraction or the worst topography. It's probably, in many cases, the eye that's not functioning well, depending a little bit on their ability to wear spectacles or contact lenses in that given eye. The trick is to get the epithelium healed. I mean, the real risk, as we all know, is a persistent epithelial defect. We expect the epithelium to be healed within a week at the max. And if the epithelium is not healed within a week, to me, that's somewhat of a medical emergency, and we need to treat that aggressively. And take the contact lens out. Typically, we see them at 4 to 7 days, and we're expecting them to be healed by that period of time. If they're not well healed, then we need to, basically treat a persistent epithelial defect protocol, which for me is to stop antibiotics and any other toxic medications, and to use frequent non-preserved lubricants, and to see the patient daily until they heal. If we allow the persistent epithelial defect to persist, many of these patients will develop very meaningful haze, and some maybe even a visually significant scar. So at about a month, we can usually refit the patient with a contact lens. Usually, the patients go back into the same glasses and or the same contact lens that they had before, and we don't really see any meaningful flattening, which does occur maybe in half of our patients, typically out until the 1-year exam. And so I basically usually get them back into the same contact and the same glasses. And to reassure the optometric community, usually we're sending the patient back to them for the management of the contact lens and or the glasses. So we talked about insurance coverage, and we are improving in that regard. And I would just say that Avedro has really gone out of their way to be helpful in this area. They have a cohort of people who will basically help whoever it is in your office that does the billing to set appropriate set of expectations for the patients, and to work with the insurance companies. And even if you have a patient who cannot afford the treatment, to provide it, the medications without cost, but you still have your time commitment to make as well. And every surgeon has to decide whether or not they are willing to make that type of commitment. There's a lot of resources out there, and the one that I like to make my patients especially available are the handouts by the National Keratoconus Foundation. And they're our partner in trying to get access to treatment for these patients. They have a really nice brochure, and then in the back of the National Keratoconus Foundation brochure, there's a little tear out that the patient can fill out and send in, and then they can be on the mailing list of the Keratoconus Foundation, and they basically get newsletters and the like, and are brought up to date. If they want to, they can get involved in patient support groups and blogs and the like. And I personally found that a very useful organization for my patients as far as support, and sometimes talking to other patients that have had the treatment as well. And there are websites that Avedro has, and most of us that do these treatments frequently have our own websites. And kind of the other official handout, if you will, is the American Academy of Ophthalmology has a brochure that you can get on keratoconus. And so I'll often take the National Keratoconus Foundation one and stick inside of it the American Academy of Ophthalmology one, and then tell them they can go on the web and certainly look at the Avedro or our own personal keratoconus information on our website as well. So safety information, again, the biggest issue for me on epithelium off cross-linking is getting the surface to heal. In a sense, the same issue that we have with PRK, but it's sometimes even a little bit more difficult in the cross-linking eye, as the epithelial defect is a little longer and the ultraviolet exposure a little greater. And take seriously any non-healing epithelial defect. Thank you very much.
Thank you, Dick. So just in the last couple of minutes, I think Dick has, not just here, but previously done a very nice job of educating all of us on some of the paradigm shift that's occurred in treatment, not just treatment, but even diagnosis of keratoconus and when to treat. So I just wanted to ask, again, Ron and George, maybe to comment on, what do you do with your co-managing doctors or referring doctors, comprehensive ophthalmologists, optometrists? Obviously, you can talk to them about some of the things you already discussed in terms of topography with Pentacam, but how do you advise them when to refer and when do you send the patients back? How do you manage that?
So it's, you know, I think it's something that we take for granted, and I'm always surprised at how much our optometric colleagues don't have a good sense about when it's appropriate to refer for cross-linking. And they may actually have a decent keratoconus population that they've been fitting with specialty lenses in their practice, but they just don't have a good sense of following progression, or even possibly sending them over even if they haven't progressed, but for evaluation. And so one of the first things that we do is we help them understand, if they have a diagnosis, if they've caught the disease, period, whether it's progressed or not, please refer them for an evaluation to see if they are a candidate for cross-linking. And that's, if I was going to teach you one thing, if you work with a referral system, that's the key. Don't take that for granted. It's unbelievable. And then, and actually the same goes with a lot of our referring non-cornea treating ophthalmologists as well. So yeah, don't wait for progression to have it evaluated. I think that's really kind of the key.
Okay. Yeah, I think some of the paradigm shift you've described, Dick, is that we now have a treatment available, which we've all waited years for. And so obviously we want to stop progression, and we all believe that treating early is better than letting the patient continue to progress, because we can't always get their vision back. So Ron, maybe the last question, and maybe a little more specific, one of the questions from the audience. Younger patient, teenager, seeing them for the first time. How do you then decide on progression, or do you decide that it's a young person, I need to treat them now?
Well, I mean, I think if you looked at even some of the ABC staging, if it's the first time you've seen them and they're already looking what looks like it's 95% confidence that it's keratoconus, and they're really young in age, you're going to have to really make a decision quickly on that patient. You may say, okay, well, we'll check you back one more time to see if it's progressing, but it's almost intuitively, it is a disease. It is keratoconus. And you got to act on it so that it doesn't progress into something that's going to be out of the range of cross-linking. The sooner, the better. I think the big thing is when a patient's coming in, or where they send it, someone is referring in a patient or sending it to you, you're going to have to collect your own maps and do your own thorough workup to be able to make that decision, not just depend on the decision of someone outside, because it may be that they didn't get all the proper information. If they have old records of previous maps and you can see obvious changes, you could maybe see that patient for the first time and say, you need cross-linking because we have demonstration of progression. Otherwise, you probably want to at least give it another exam to see if there is progression, unless it's an obvious younger patient where you know, waiting is going to be really detrimental.
Yeah, so if you have a young patient, don't tell them to come back in a year to see if they progress. You know, we need to bring them back in maybe 3 months.
I've heard stories where doctors said, oh yeah, they counseled, you know, the family and everything, and they said, let's see you back in 6 months. And then they got lost to follow-up, and they came a year and a half later, and they were already way out of control, even where cross-linking wasn't possible. So you could really miss the opportunity by not just being diligent right from the start.
And I found often these patients will have old glasses, or maybe old glasses refractions, and you know, we have a lot of progressive myopia in the world nowadays, but it's still, if you have the old glasses and they have definitive keratoconus on topography, I think you can define that as a progression. So if they were you know, -3 +2, you know, 2 years ago, and now they're -5 +4, and it's keratoconus. That's to me documented progression. So
I think another interesting question is if you treated the first eye because it was clearly progressing, and now you're looking at the second eye and you're saying, I'm kind of wondering if that's progressing. Don't lose track of that eye, because that one could progress pretty quickly too.
and it's the more important eye.
It is. It's the
have a
better of the
problem.
two. That's right.
So,
And the patients are less inclined to have that eye touched, by the way, because they're so debilitated by the other one. So that really takes some careful consideration and counseling of the importance of treating their good eye to prevent it from becoming like their bad eye.
yeah.
So let me thank our distinguished panel, Ron, Dick, George, and thank you all for the questions, comments, as well as staying and listening to all of us. So we'll all be around, but have a great evening.